Well, welcome everyone to the next episode of the AOS Podcast. We have some great doctors here with us today. Dr. Williams, Dr. Vierthaler and Dr. Standridge. And today we're going to talk about different treatment modalities for ortho.
Yeah, so I'm Matthew Standridge. Been an AOS member for about 11 years, and cut my teeth with straight wire, and I've been doing that. Been doing straight wire for about 14 years, and that's still one of my go-to mechanics. But over time, I've done more and more education into aligner therapy, and started really going down that path about 10 years ago, and then it started becoming a big part of my practice about 5 years ago. And so I practice in Stroud, Oklahoma, and I now teach the Digital Aligner Bootcamp course here at the AOS.
I am Brian Vierthaler. Practice in Maryville, Missouri. Been in AOS for a long time. I have no idea how long. Started my orthodontic journey a long time ago when a patient needed a simple tooth uprighted for a bridge I was going to do. And the patient did not want to pay the $5,000 to get it done. And I didn't know how to do it, so I figured I'd learn. Well, start crawling down that rabbit hole. Run into guys like Dr. Williams, was actually back then a associate instructor with Dr. Jackson. And I started out with the other organization other than the AOS, and then I ended up at the AOS and got sucked in and just pulled 2 feet deep. So that's why I started that. I primarily do straight wire. I am not like him. And it's a good thing because I know we'll talk about it today. I'm not a big fan of aligner. I think aligners have a place. I don't use them near as much as he does. Why? Because I'm not as good at it, apparently, and I think it's a pain in the ass sometimes. And I don't like relying on my patients to move teeth. I like having control because most dentists are control freaks. But admittedly so, I don't have the experience that I'm sure he does. I guess maybe I couldn't take enough punches in the face and get through it. I just tapped out. Not tapped out, I still use it. Anyway, so I'm probably completely different than him, but happy to be here. Maybe I got the wrong email because these two guys are way smarter than me. But anyway, I'm in Maryville, Missouri. We have bigger practice of 11 chairs. Do implants. Got a couple guys I work with that are diplomates with that. And we do kind of it all. Northwest Missouri State, university town. It's a cool town and love it.
I'm Dr. Brad Williams. Currently I'm the AOS basic course and intermediate course instructor. I've been in the AOS for 40.
World War II started, so just go off of that number.
About 42 years, I think, something like that. Anyway, a long time. And I've been in practice in Skytook, Oklahoma for 43 years. And I'm still currently in full-time practice today. And I've been doing orthodontics pretty much ever since I got out of school. But I turned to the AOS to learn good clinical orthodontics. I did get a good basic education in orthodontics when I was at Oklahoma University College of Dentistry under Nanda and Dr. Franz Courier. They didn't have a residency then, so they actually did have a good solid 4-year curriculum. But it was really 4 years of teaching me more about why I shouldn't do orthodontics in my practice than about why I should. And they had a lot of good scare tactics. So when I got out, I really wanted to do it, so I found the AOS, and Dr. Charles Yates was teaching BEG orthodontics, which is an Australian technique. And I learned that first, and then I went, when Pete Kessling came up with Tip Edge, I ran up there and took his course. He and Rocky and Raleigh Williams were teaching that class, and which it was really great to get to be instructed by guys like that. It was really cool. But I then transitioned out of tip edge into straight wire, and been doing straight wire ever since. I'm a fixed appliance guy as a rule. I do aligners in my practice. Very, very few of my aligner cases stay pure aligner cases. Most of them, at the patient's request, become hybrid, and we end up doing some fixed work as well.
I guess to start off, maybe we could talk a little bit about what are the different treatment modalities for orthodontics, and what has your experience been with them?
Well, I've done beg and tip edge and straight wire, and I've dabbled in all sorts of removable appliances that are out there, and over the years. And then when aligners came along, I dove into that, which, Invisalign actually approached the AOS first. We were one of the earliest. When they were turned down by the orthodontists, we were one of their earliest appearances, because we had them come. The AOS has always been pretty open about new stuff and new techniques and that sort of thing. And I don't know the year, but it was before they released it to the public, before they started marketing to the general public. They'd come to the AOS and pitched it to us, and we had them at one of the meetings. I think I wrote a 7,000 word blog on my website about why I thought aligners were not that great. But I've modified that, and I try my best not to get that narrow-minded, all that cognitive dissonance kind of thing where, you shut out all these things that you don't want to believe in. But I think it was really an interview. I heard Dr. Franz Courier talking about aligners, which he was one of my, my earliest instructors, and a brilliant guy. And he was like saying, yeah, he could see how, aligners could be, certainly be one of the big futures, and had a lot of potential. And so I had to kind of revisit that. I think, there are aligners, and there's lots and lots of different products out there. There's a bazillion products, and everybody's got their own bracket, and their own, there's fast braces and 6-month smiles, and Progressive has all their stuff. And, at least that's one refreshing thing about the AOS, is they're not trying to, as an organization, they're not trying to sell you some specific vendor's hardware or some specific technique or anything like that. We all will certainly share what we use, and why we're using it, and the vendors we use and why we use them. But we're not like, you've got to buy this from us, and that always bothers me whenever I've got a outfit that's got their own brand and their own product and
their own lab services.
The whole nine yards.
Yeah, we'll supply you with the brackets and the wires and the indirect bonding trays. Just buy everything from us. Yeah,
Make this
exactly.
easier.
Yeah.
So yeah, what I love, like what Brad was talking about with, I'm a firm believer a GP is going to go really kind of dive deep into orthodontics. I personally think they should know both. I think they should know straight wire, and I think they should know aligners. And what got me to doing more aligners, because I saw the market demand for it coming down the pike. So that's why back in 2014, I started doing it, and I did not like it at first for quite some time. But it wasn't until about 6 or 7 years ago I started really reading textbooks. I started learning from educators in Japan and Brazil, and people who weren't on the company dole per se. They were just really going out there and teaching what they know. Because one of the things that frustrated me about all these different aligner certification courses that you go through was basically it's a doctor for a day or maybe just a half a day talking about showing before and afters of their cases. And I don't even know if they were their cases, to be honest, but or if they were just fed by the companies. But they're showing before and afters of these cases. And yeah, we started here. This is where we got to, all that stuff. And it's so easy. All I have to do is take the impressions, and that would be the scans, and send them in, and they'll do the work. And it's so easy, and it's made me so much money. And that's kind of how the certification courses were. And you go at the end of it, it's like, I still don't know a darn thing about how aligners work. Yeah, that's when I started reading textbooks that were coming out on clear aligner therapy and all that stuff. And then what I think really pivoted for me was when I started, once I learned how aligners work, how attachments work, how different designs of the plastic, straight versus scalloped, equal gingival versus, a millimeter, 2 millimeters above the gum, all those have vastly different physical properties. But I didn't know that. And so it wasn't until I started learning that, and then started learning concepts of overcorrection and stuff like that. And then all of a sudden, a switch went in my head. It's like, okay, well, I know how to, if I need more buccal root torque on a molar, I know how to detorque a rectangular wire. Well, now I know how I can do that with aligners. Or if I need to open a bite, and we know how to use accentuating curves or reverse curves in a wire, well, now I know I can program that in to the workflow with the aligners. And so when that started to click for me, that's when I started getting a lot better results. And then couple that with the materials and working with a company that had better materials or better tray design or accurate printing models, because rumor is, allegedly, there are companies out there that are big name companies that their printers print at 200 to 250 microns of accuracy. Well, the ABO even recommends, if you do 3D printing for aligners, the model needs to be 100 or less. But you have big players that are less than half of that. And so all of these things come into equation. It's almost like, yeah, you could get, you can buy brackets nowadays on Amazon for 20 cards of sleeve. But that doesn't mean they're going to be any good, right? And so it's just all these things into effect. And so so luckily with that, that's what's gotten me to now, I'm about 60% aligners, 40% brackets. But I wouldn't be where I'm at had I not had that deep knowledge with straight wire and my years really working with that. I would have never got to this point. And then, and also to hybrid therapy, there'll be cases where I just get the big stuff done with 6 or 8 months of straight wire, and then I'll finish up with aligners, depending on the case. So I love having both modalities in our back pocket. And I'll just finish with this. I say this in my courses a lot, that learning orthodontics, learning implants, learning cosmetics, nothing made me a better general dentist, than learning orthodontics. Like, it leveled up every aspect of my overall practice and my ability to give care. So,
couldn't agree with your last statement more. How it's not a requirement, it just blows my mind, because it literally, when you're prepping a crown, you're like, oh, this person's never had ortho. I can tell by, the root torque on this molar that you've never, and your teeth are really straight or whatever. Everything from treatment planning, bigger cases, occlusion, all that stuff. Mm-hmm. If I was in control of things, it's probably a good thing that I'm not. You would not be allowed to do aligner therapy unless you had a basic education of straight wire. Mm-hmm. Because I think it's absolute, and this is just my opinion, it is absolute insanity. You're going to take a course and you're going to listen to a doctor for a half a day, like you said, and then all of a sudden the rest of the course is how to get information that goes God knows where, diagnosed by God knows who. So when I started, it's like you're right though. What was driving it? It wasn't. I think it's a good idea because kids forget to freaking brush, and I'm gonna all of a sudden give them 52 trays, and they're gonna wear all these trays. Are you kidding me? So it just didn't seem like a good concept. But why was I looking at doing it? Oh well, moms, hey, we don't know how to do regular braces. Oh, okay. Well, I'm gonna start getting into aligners, right? So that's kind of what pushes the whole thing, but it makes it messes it up when you don't have a basic knowledge of what you're doing. But what's funny, you said that too, because what I've kind of started doing more of is the heavy lifting, the hybrid cases, the heavy lifting, the straight wire, get everything pretty damn close. And then it's like, yeah, we're wearing a few trays here at the end. Yep. I can trust this kid. This kid's got good hygiene. This kid's doing this. It seems like competent, and then, cause that was my biggest beef. I have no doubt, physiologically you're moving teeth and it works out. And I've seen great cases. There was an orthodontist that, lived near me, and I just started referring them all there. Yeah, you want aligners, go there. I'd rather not do it. I like predictable. I like less. I like low stress. I still been doing this for 20 some years. Still absolutely love my job, which talking to guys, you graduate, how many guys don't like their job? A lot. It can be a high stress environment, and I like to remove stress, and I want predictable, and I want the highest probability of ending up here. No, he's been wearing them. You got mom, hawk in the corner. No, he's been wearing them. So now I got a choice. You're getting a pissing contest with her to say that he's not wearing them, and then poor little Jimmy has never made a mistake in his whole life, right? But I can see the little vape pen in Jimmy's pocket, and mom's not paying attention. So, okay, I guess we'll just step back a few, and I'll see if I can find one that fits. So this is fun, right? And what also is funny to me is, if you can get an orthodontist to talk to you, like, you know what I mean, like, just honestly, and I've got a couple guys that specialists that are fantastic, and everyone that I've asked, everyone, I'm like, do you like aligners? No, hate it. Why do you do it? Because people come in and ask for it. It's that. But I also will wholeheartedly admit, I didn't, that learning curve where everybody talks about, the struggle.
Oh yeah.
I quit before.
Yeah.
before getting through that. Yeah. To where you get to that promised land of, okay, I see it. It's just, but and maybe it's a delivery issue with communication, but I feel like I'm pretty decent at that. But hell, half the time I can't get people to freaking brush their teeth. And then it's like the consistency. Oh, well, no, I watched a commercial. You wear these 4 hours a day. I'm like, oh, there's commercial. Yeah, there's, whatever the misinformation that's out there, and then I'm just kind of like, yeah, I'm pretty busy. Again, I look at it and go, this just looks like stress to me, and I've got enough, and I'm busy enough to where if I don't, but like I said, I have, it's on my to-do list because I think I am missing the boat a little bit on my knowledge level isn't nearly what obviously yours is with it, and I'll put that on me. But those are kind of my 2 cents on that. But I can actually remember how dumb I was. My dad taught at the dental school for 34 years, and I remember him telling me, and it's funny, the older you get, you're kind of like, okay, he was right about that too. Oh shit, he was right about that too, right? Is he always told me, he's like, dental school will teach you enough not to hurt anybody, and then you learn dentistry your first 5 years out. Take a ton of classes, and I think it's 100% true. And for kids to take a class, and you're taking somebody's money, and you're taking little Jimmy, and mom's trusting you, and you have no clue how to move a tooth, you just got this packet of trays, and then mom's asking you questions like, what, how come on this one's this, and you're going, that'll work out. Yeah, it's all part of the programming, you're coming up with something out your butt because you really don't know what's going on. It's not, well, first we're developing this way, and we're doing this, and this is, the bite's going to open, and then you can't explain that because you have no clue. Yeah. I can't even believe it's legal, to be honest with you. But I mean, I'm serious, and I know piss people off on that. But if you talk to back to what you said, if you talk to all those people that signed up for all those courses, And why did you do it? I had a guy in my own town. He was super nice. He at least admitted, he's like, dude, I shouldn't have done this. I have no clue. And I was like, okay, we'll get you out of it. But it's like, it's the stresses. It's you're out, you're practicing, and it's $7,000 or whatever you're charging for a full case. But it's kind of like, to me, in my head, in my brain, and I'm not saying I'm right, but for me personally, there's always a line of what I'm going to do. You know, like with endo, I do a lot of my own root canals.
Yeah.
You know, about 80% I'm comfortable with, because I feel like I can do them just as good as my stud endodontist, you know, in the next town, who was a good friend of mine. Same thing with oral surgery. Wisdom teeth, we do wisdom teeth. It's like, you can do that. There's a line. You know, I always tell people, it's like, legally I can take bone out of your hip and screw it into your jaw. Should I be doing that? No, absolutely not, but I can do it. You know what I mean? It's kind of crazy. Anyway.
So it seems like, you know, a consensus certainly is that understanding the foundations of tooth movement, understanding growth, all of those types of things is important as a prerequisite of picking a treatment modality. And
because the problem with that is, if you don't understand that, you don't see the train that's going to wreck.
Yep.
You know what I mean? And then it's like, what are you going to do about it? But you don't have the diagnostic ability to look at yourself and look at this and look at mom and dad and go, yeah, this is going to be bad.
I mean, again, if you're just depending on some company, you know, let's pick on Invisalign, and say they're going to green light your case or not, and they make money if you green light the case, it's probably going to get green lighted. And to me, that knowledge is critical. I don't want to depend on some tech who's running some kind of algorithm, you know, that is going to compute the tooth movements and create the aligner series, and he doesn't know anything about orthodontics either. You know, he's just running an algorithm. And my experience with predictive algorithms, you know, I always think of the weather. That's the earliest application of predictive algorithms I can think of, and we still suck at it. I mean, you know, it'll do a good job for about 24, 48 hours, but after that first couple of days, the weather algorithms break down and you start deviating, you know, real rapidly. And so
It's a good analogy. I like that.
the whole concept of producing 40 trays on an algorithm really disturbs me, because I just see it starting to deviate. And the more complex the case, or if your case selection sucks, then you're going to get more deviation from that predictive model. And so you're going to end up with your trays warping and not fitting and not seating well, and the tooth movements get worse and worse. And then you're into refinements. And you have to do refinement after refinement. And you had nothing to do with any of the planning, because you don't know anything about orthodontics.
So they'll sidestep that and they'll say, well, yeah, you did. You checked the boxes. But I know if I were to watch you get whoever you use as plan back, he's going to sit down and go, nope, click. I don't like what they did here. Nope, I want, nope, plus turn this to, he's going to go through it all. Right. Okay, what percentage of people do you believe are actually doing what he's doing? I'm just guessing. But I'm betting the majority of those ClinCheck people are.
Yeah, because the animation looks great, but I can always say in class, just because my character on Madden football can jump up 10 feet in the air and catch the ball doesn't mean that's what's going to happen in real life, right? And so, but that's the thing. If people don't know, all they see is this pretty animation of it just straightening it out magically, right? Yeah. And then they, hey, that looks good. And you hit click. And so that's where, yeah, like you just said, understanding tooth movements and like, okay, so you have a tooth. This tooth is, you're in a scallop tray with no attachments, and it shows that we're getting 2 millimeters of extrusion. Right. How's that going to happen? Like, and I think it really comes down, and Brad, you alluded to this, it really comes down to diagnosis and case selection, but that's where a lot in the aligner education space have failed. and not only that, but we don't have great just diagnostic education to begin with. Like my first course when I started on my own in 2019, it was called Ortho Foundations. It was a weekend of just it would be similar to probably to your first weekend, where it's like understanding cephs and understanding, transverse, sagittal, all that stuff. And the way that I talked about it was it's the ortho we should have learned in dental school. Like this is the education you should have learned in dental school, understanding vertical relationship, deep bite versus open bite, and how to read the transverse and all that stuff. And until you really get to understanding those things, because it all comes down to, just like you were saying, the way I look at it is green light, yellow light, red light cases. And you have that. You have your 20% in your wisdom teeth that are red light cases that or molar root canals. If I see this gets a referral, right? But you don't know that if you're diagnosed.
Don't know what you don't know.
You don't know what you don't know, exactly.
Yep.
And so that's why I think getting that diagnostic background is very, very important, because without it, you can just get into so much trouble. Like if you have, for example, a person who only has 1 millimeter of overbite, and on their ceph, whether you take Williams or you take Sassoon or whatever, they're they're skeletally hyperdivergent or open. They can slip into an open bite or an underbite very quickly if you don't know what you're doing. But if you don't know how to look for those things.
Yeah, I mean, that, to me, again, it just comes back to education, and there's no question that aligners are just another tool. It doesn't matter whether you're doing fixed or removable appliances, and they all have their place. And I think it's really valuable. I see aligners for me is one of those bailouts that, like, if I've got an open bite case, something that's really hyper, if you use fixed appliances on a case like that, they've really got a high growth, vertical growth pattern, their bite's going to open. But I can be pretty certain that an aligner therapy is going to get intrusion of their posterior teeth, and that the bite's going to close. So, I would much rather tackle a case like that with aligners than put braces on their teeth and deal with an open bite. Right. So, there's plenty of applications. There are a lot of applications, just like you were saying. I would never put anybody in aligners that didn't pay for it. If a kid is, if the parents are paying for it, then they're probably not going to appreciate it and they're not going to comply. At least an adult has got skin in the game, and so I expect that they'll wear them. So that's one of those lines I draw. I'm not going to put aligners on a kid. My biggest concern is that for most practitioners, aligners are going to give typically a rougher finish, and there's some things that they're not going to do well, or you're going into it for the wrong reasons, like you're really not interested in comprehensive, you're just trying to dress up a case. A lot of adults just want some minor fixes. I have no problem with that, and that doesn't matter if it's 6-month smiles or fast braces or aligners, as long as that compromised treatment is framed that way. The big problem is that that's not a discussion that is, when you're trying to sell the case, you just kind of dodge the whole informed consent thing, because it's our responsibility to tell a patient if we are doing a compromise, if we're going to do something that's less than comprehensive, we need to tell them the consequences of that. And then as long as they're okay with the consequences of that, if we only straighten up these teeth, we're still going to have these problems. And as long as that's on the table, then you've made an honest, professional job of it. Yeah. But if we sidestep that, then they have not been informed.
Yeah, I mean, you're exactly right. General public, who I always tell the girls, you forget how dumb you were when you got here. And not to say that meanly, but like, you're so used to looking at teeth and, it's buccal, it's on the distal, it's all, it's tooth number 4, it's freaking common sense. Well, imagine coming in as a patient and it's, well, he wants to do, what did you say, 24 months? Holy shit, 24 months. You got to come in here every month? Hey, what do you, 6 months? He can straighten my teeth in 6 months, and they're going to look freaking great, and all my selfies are going to be amazing. Who am I going to go with? Right. If you're not actually informing people, and they don't know any better. And I mean, you could have very, very smart people, but you know how it works. They don't. I always joke, like physicians, the level of we take for granted, like we've basically studied the mouth for our entire life. Well, the physicians back when we were in school would get like 3-hour lecture from the pathology instructors. And so, funny story, real quick. I'd already had all my requirements, so I was going to be kind of lazy and read the paper and drink coffee. They needed a couple senior dental students to go, babysit while the med students were going over doing exams in schools. So I'm thinking, I'll just freaking sit there all morning. I'll get credit for it, whatever. I get my paper out. Perfect, right? And first minute, one of the med students comes over. I need you. Okay, you got something? Yeah, hey, we got something. What do you think it is? And I think it's cancer. I said, holy crap, you got freaking cancer. No, it's on the tongue. It's supposed to be normal. Okay, yeah, it's normal. Same thing. This happened like 8 times the whole morning. We got cancer. What is it? That's actually bone. You know what I mean? But it's like, imagine the average person coming in. They're going to believe, people are trusting, and therein lies the freaking problem with it. If everybody was honest about aligners, that's what I think gives some GPs also a bad name doing ortho. Right? It's, well, this guy does ortho. No, he doesn't. He does Invisalign. He doesn't know jack. But you always have to be able, I think you talked about it a long time ago in classes, or maybe it was Dave. It was like, you have to be able to bail yourself out. And you'll know you're good when you can do the same thing 6 different ways. Yeah, I could fix this I could do this, or this. Right? And then you kind of, you're stop, I always call it stop cookbooking and become a chef.
So a couple questions on that. One is, are there certain cases where Invisalign is superior treatment modality, and are there cases where only brackets and wires will get you the result that you're trying to achieve?
Well, I already alluded to that for me, if I've got an open bite case, that or one that's likely to go there, and I can do it in aligners, that would be great, because it is really hard to manage vertical growth patterns with fixed appliances. So that it's great for that.
Well, I mean, I just think of the case I literally saw yesterday. Scanned her up for refinement because number 27 just needs about 10 degrees more rotation. But everything else was great. But she came to me. I hadn't seen her for about 5 years. And she came to me last March, a little over a year ago. And she had developed diastema. So she has these old PFM crowns, canine to canine, just real gnarly gums, and she had developed about 2 millimeter diastema and 100% deep bite, and I wasn't like that last time I saw her. And so she came to me for that. And so, she had already done about 40% wear of the lower incisors. She has a broken number 19 going on there that needs endo crown. And like I said, she has about 2 millimeter diastema, 100% overbite. And so, and she had a very toothy, like on her smile arc, her upper incisors is super erupted as well, combination syndrome with over eruption of the lower incisors, all that stuff. And so I literally just saw her yesterday to scan up for a refinement because everything looks great. Just need a little bit more rotation on this guy down here. And in 12 months, we've gotten her curve of speed flattened out. We've got the diastema closed. We've got a great incisor display. These being PFMs, I wouldn't have been able to really confidently put brackets on those teeth. And so like I personally love aligners for deep bite cases. I open up deep bites so much more predictably with aligners compared to brackets. That being said, I had to learn how to do that because there's certain types of programming, like setting up the case, of the concept of what I call, concept that's called overcorrection. But this is why I don't show my ClinChecks to the patients, because they look like crap, because I put in all these overcorrections. If you show a layman that, they're like, what is this?
Yeah, I'm paying for that.
But I started looking at these programming softwares as viewing the teeth as forces applied to teeth, not in tooth position. And so that was the big, aha moment for me. And so, yeah, and so in a case like that, and like I said, deep bite cases, I love. But there are certain things that I know I'm going to use braces for, and that's a big thing of that is if I know right off the bat that I'm going to need distalization mechanics, then I'm going to prefer braces. Now, I could do a hybrid treatment where I start with a fixed appliance to get those molars back, but even then you have to bodily move and translate the premolars, the canines, retract. Those are mechanics that are just more, I'm more confident in straight wire in for those, because certain movements, intrusion, like anterior intrusion, aligners work great because you have this huge incisal surface area for the aligner to push on. But bodily movements like translation's hard to do with steel and rubber bands.
Nope.
Of course, it's going to be even harder to do with plastic.
Yeah, I think that sagittal corrections are infinitely easier with fixed appliances, right, and are really, really challenging. And you really have to jump through some crazy hoops sometimes in aligners to try to get some kind of an anterior posterior correction. Yeah. And so again, it's all about case selection. And for the average general dentist out there doing aligners, I think they really depend way too heavily on IPR. And that always annoyed me, and it used to be it was even worse. They're getting better, but John Sheridan definitely made rotary stripping okay. All of his research was good. So did, who is it, Zerkson or whoever, Bjorn Zerkson did a bunch of work in that area. And so we got the green light. You're allowed to saw on teeth, interproximally to make space. But I just see it abused so much if you just, again, leave it to the algorithm. Because the algorithm, as a rule, doesn't go for a lot of transverse expansion. Right. It'll stay on track with what they'll be saying. We're going to keep the teeth over the basal bone and over and we don't want to expand out.
Because it becomes unstable.
Exactly.
Yeah.
And it's a great excuse to shorten the number of trays you're going to need, and you'll make up for it by sawing on teeth, and I don't like that. And even as far back as like when Dr. Jackson was teaching, he used to address that and say, no matter what they say, you just have to specify that if you're going to do a liner, you want some transverse, some width before anything else. Then he turned around and IPR'd the crap out of his wife. But it was one of the worst IPR cases I've ever seen. He just used to show that with like, this is what not to do, but at least he did it, to his wife. But
it was all in good time.
Yeah, yeah. Start on family members, mess up on them, and then yeah.
But
what's wrong with your teeth? My dad was a dentist.
But no, I think that I think aligner therapy is definitely here to stay, and I think that I see myself mixing them all the time. So hybridizing cases, because a lot of that stuff, sagittal cases, a lot of times if I've got everything in place, then yeah, we can go ahead and just finish up with a liner, or sometimes it's easier to start out in aligners, and they get, and you just can't create a nice crisp finish with the aligner, and the patient's running out of steam on compliance, and we'll just say, look, let me put braces on for a month and a half, and we'll be out, and finish it up that way. I think that the technology and the advances are amazing. For me, I like to design my own aligners. We make them in our office. I design them myself, and I only usually create like 10 trays or so at a time, and then usually I'm going to stop and scan again and remap the whole case and do the next series with a whole new. So I don't manufacture a bunch of trays that I don't like.
Yeah.
You know, I'll just do short segmental kind of things. But for me, who would have believed that stuff was even possible?
Yeah.
When I started in practice, we didn't have computers. You know, we didn't have cell phones. We didn't. You know, our appointment books were in pencil, so you can erase.
I forget the first
so it's
doc
crazy.
who did in-house aligners. I think it was back in 1943. It's for minor tooth movement, and so they would be doing model surgery. You know, pouring up staging models, doing model surgeries, doing vacuum form, and all that stuff.
You gotta get
So
some,
it's as old as in the 1940s.
you gotta get some hobbies. But you know, though, they do this shit stuff they do this all the freaking time, and they do it with everything. They try to oversimplify, and they sell it. And again, the problem is you don't know what you don't know. It's like the old, they've done it with endo. It's like, oh, well, you just run one file and you just do this, and then you put this in there, and it's good. And it's like, is it? Or no prep veneers. There's times that things are going to work, and there's times that not. But if you don't have the diagnostic IQ, right? And that's my issue. Is it's almost, I feel like they're burying these freaking kids in debt, right? Like you bury. And I'm not judging anybody if somebody's listening. Don't get my email. No, but I'm not judging anybody who does anything, because I believe everybody's trying to do their best, and I would hope everybody's trying to do their best. But it's like you bury these kids in debt, and then you get out, and then you've taken dental school classes from 80 to 120, and you've got all these dentists, and you're in the loans aren't the low interest stuff that I had. I mean, it was like super, super ridiculous low. You're pushing these kids 6, 7, 8%, paying off $500,000, and they're just trying to make it. And it's like, okay, I got this practice. What is this? Aligners. Oh, okay. I'm interested. I've got good intentions and all this, and then somebody's lying to you and telling you this weekend. Well, and then all you're doing is setting them up, and then they're doing stuff, and then they're having anxiety because it's not working the way it wanted, and all of a sudden I hate my job, and dentistry sucks, and it's like, well, no, it doesn't. They didn't teach you all this. You need to learn all this, and then you'll get to the point where you'll like it, and it's fun, and it's predictable, and you have some job satisfaction.
How many aligner courses, that got taught you don't need Ceph as part of your diagnosis? It's just one example of lying to you, because that just tells you that company is telling you that you don't need to diagnose this, we've got it. That's basically it. And it's like giving you permission to not know the basics. And that does not work out well. Teresa and I were going through applications from doctors that were going to sign on for Premier, and they had to have a good standing with their board. And we ran into guys that had some board actions, and some of the board actions, more than one, was a board action because they had done orthodontics, and cited in the findings was that they did not have Ceph. And they did no Ceph analysis, did no diagnosis, did no treatment plan. It wasn't in their chart.
Why can't we normalize dentists having Cephs? Dentists have cone beams right and left anymore. It's not that much more to just add on a friggin' 2D Ceph, or get a large enough cone beam to where you can get a full field.
That's what we do.
Why? I mean, they're not. I just bought, 3 years ago, I bought a new Carestream with a pretty good size field of view cone beam with a 2D Ceph for like $75,000. Why can't we just normalize and start making it more of a requirement? Say, hey, if you're ever going to do any type of orthodontics, just plan on getting a Ceph.
I make it a necessity. When I'm teaching the class, that's not an option, because it's really malpractice to not have a diagnosis. And that's part of the diagnosis, part of the basic standard of care diagnosis in an orthodontic case. And Invisalign or any aligner, it is orthodontics. I just priced a new, because I run Carestream, which was Kodak when I bought it. That's why I'm having to replace it. As $60,000, and I'm going to have twice the field in my cone beam, and it does 2D Ceph and pan, and I paid 4 times that in 2008 for that machine. I mean, that's really pretty affordable.
Well, it's, we've always talked like, what's the standard of care going to be for wisdom teeth? Like, you still okay with the pano?
Right.
I would prefer
implants.
Or implants.
Cone beam should be standard of care.
That's exactly right. Because I don't want anybody cutting anything out on me that can't see it in 3 dimensions.
Right.
We'd always joked, with the old implants. But with them dumbing it down, they're running these courses for implants, and we obviously do a lot of implants and full rehabilitation cases. I don't, my partners do, and we see it all the time coming from, we won't say names. Do you know what I mean? But they dumb this down to where they tell a kid, it's like, you order a stent, and then you just drills. You can't mess this up. You can't. It's easy. Just drill it. Let's go in the back of my van. Let me show you how this works. Right? It's the truth. And then, but in my head, it's like, if you can't lay a flap, you shouldn't be doing it.
Visualization.
If you're not comfortable surgically doing that, you shouldn't be placing an implant. Right. I'm sorry, you shouldn't, because what's going to happen how are you going to graft? You're going to graft. You're going to use, whatever. If you're not comfortable doing that, take more classes then maybe at the end, hey, I really like these stents. These make it predictable in this, but I have the tools in my bag to handle if something doesn't. Same thing with the ortho. I have the tools in my bag to fix this if it doesn't go exactly like but let's dumb it down, let's dumb it down. Cone beam, I always joked when the cone beam came out, I always look for stuff like, by the time I retire, what are, the next generation-ish going to look back and go, are you serious? You guys used to do it this way? Right. And I was like, I think it's going to be cone beam. I still give, Twaddle a bunch of crap, because when I even first started, it was you'd hold the pan and then you had these little magnification implants and you'd hold it up. And I'm like, that is so insane right now to think about after watching them treatment plan, thousands of implants, and you're looking at the bone and you can tell you're freaking
it's just, if anything, the provider who knows the least needs the most diagnostic equipment, because a general dentist and pediatric dentist need to decide which cases they're going to treat and which ones they're going to not treat. You can't make that decision without all this diagnostic input. And whereas the orthodontist, he could just do the thing that used to be the Ceph. They called it the orthodontic salute, holding the Ceph up, and that was their Ceph analysis, because they knew they were going to treat the case, and they were going to treat the case on the fly, and they make adjustments on the fly because they know what they're doing. But somebody who's really, there's some things they're just not going to be able to treat. They need to know,
Well, it's like, Brad, I'm sure you still do Cephs on all of your cases, but how many times are you surprised, like when you look at a Ceph? Because you've done it. You have so many hundreds of cases under your belt that you get to a point that you can look at a case and you recognize it. And so maybe we still want to do the Cephs, but we're not surprised by the numbers anymore, right? We kind of knew that's exactly what was going on because we have the repetitions to be able to recognize that. But like you said, the newbies, they don't know what a proper interincisal angle looks like, or A to B, or all that stuff. And so like, they don't know how to recognize that stuff without getting those numbers. And so, yeah, you're right. The people who are the earliest in this, they need those things the most.
You guys did a fantastic job, not to promote the AOS. No, but you really did do a fantastic job of beating in the diagnosis part in the standard. And I would always sit in the back of the classroom. You guys would allow us to bring up our cases, when you first start. And I would watch, and I'd be like, yeah, they're not going to be doing ortho in a year. Because you would see these x-rays in these photographs, and it would kind of look like a snuff film type quality, like made on an 8 millimeter. But it's the proudest moment I've ever had. It hasn't any to do with any cases of any mom posting to Facebook, thank you, senior pictures. None of that. It's when one of my orthodontist buddies, he's whatever, he's a specialist, but he's done the extra, and it's one of the smartest dudes I ever met. and he was literally at her office, and I'm sitting down there treatment planning. Because I still do it different. I don't do it same day. I still force myself. They take records. I meet mom. I also want to meet mom to see if I want mom in my office every month.
Yeah.
That sounds terrible. But that's what you guys taught us is if you're going to, you have to do it up here. You have to do it to here. Because if anybody has any questions, it's like, yeah, take a look at these, man. I'm freaking proud. Every picture is fantastic. I mean, it almost, try to shoot for board quality pictures, x-rays, diagnosis, everything. And maybe that's why I still like what I do and I'm keep myself out of trouble is you can't take the weekend van course and start taking people's money.
Yeah, you want those records to be proud of those records, and you want to think, okay, what if I don't get to finish this case? What if I have to transfer this case? What if I have to send this case to an orthodontist? Do I have records that I am perfectly fine with sharing, or is that going to be a change your shorts moment?
You always had so much patience with because I'd be like, hey. Yeah, here's your money back. This isn't going to work for you. If this is what you're bringing me, you know what I mean? I guarantee you, if you bought records for their first case, you'd be like, he's going to judge me. I know I'm not going to. I don't want to bring this case because you're going to be crazy about how detailed it are. And he's just like, yeah, okay, go back and get some new records, and we'll take a peek at it because you don't have this, or this. No, but I got pictures on my phone.
Yeah.
It's like I would be like, here's your money back. I can't do this anymore. Anyway, funny.
Thank you all for being part of this conversation, and I think it's a lot of good insight for people, a lot of things to take away.